Uh, Let me introduce my panelist, Dr. Rangnath Daruru, who is a chairperson of the PIDA and a senior consultant. The another panelist is Dr. Sungarvelu. He is the Vice President of IAP from Tamil Nadu. We have Dr. Mahesh Mohite, very well known intensivist as well as a good friend of mine from Panvel. Dr. Manish Mehta, again intensivist and a friend from Ahmedabad.
All right, so can we have a huge round of applause for all the experienced dignitaries standing and sitting on the stage? And with this, I think we can go ahead with the session.
Yeah, friends, when Kunal gave me this topic, I was little, perturbed, as I thought this topic is for Pramod and not for me. So I just called him that, what do you want me to talk on? Oops, I forgot. Is this some social meeting or professional? Because I remember socially, my wife is always calling me that you always forget it. So again, I was little perturbed that why, in this type of meeting I am called for. But then I realized that I must have also made so many mistakes initially in the professional life also, that you always retrospectively feel that, oh, I had missed this and that is why I had missed the diagnosis. To start with, I remember one case just before few months, that one of the VIP family, politician who is sitting MP's granddaughter, was brought to me by their parents. She's a 10-year-old and she had fever since morning only, and then they came to me in the afternoon that she has a pain and generalized body ache. So I knew the second child in the family, younger, had suffered from viral URI just before few days, and so I thought that she must be also suffering from the viral fever. I just said that take paracetamol only and let's wait, nothing needs to be done. After third day, mother informed that child is having redness of oral cavity, but fever is mild, going down. So I thought it is just still a viral and she is responding. But then on day 4, mother posted photos to me, and oh, I realized that I had made a mistake. This is something different than what normally we get in a viral illness. And then I realized that this child had come from the other place. She was not in the same family where the younger child was there. She came to me from another city, so she had no contact, and she had contact with other group, and she had then this was a scarlet fever. So sometimes you inadvertently make a mistake because there is some fixed ideas in mind that there is a history of viral fever in the family, but you need to ask some more details and then realize that the diagnosis could be different. So friends, today we'll talk of few cases where me or some of the other previous consultants had missed something, and that is why child suffered or we could not reach to the diagnosis. Let's see the first case. 10-month-old male child had complaints of cough, cold, fever and breathlessness since last 10 days or so. There was a history of recurrent cold and cough since last 1 month. Parents consulted on a OPD basis to a consultant. He treated him initially with oral antibiotics and other supportive treatment. As there was no improvement, child was hospitalized. Child was given IV antibiotics at home, and then ultimately child was hospitalized. Child was diagnosed as pneumonia with high count. So antibiotics were upgraded to Piptas and Vanco, IV fluids and oxygen. They continued for 6 days. There was no improvement. And by clinically as well as investigation wise, child was worsening. So then that consultant referred to other hospital at local level, senior pediatrician. He also did some of the investigations, and there was again same thing, neutrophilic predominance of the count. The inflammatory markers were high. Chest X-ray revealed that there is a increased dense opacity on right side with coarse crepitations predominant on upper zone. So he upgraded to meropenem and vancomycin and waited for 72 hours. As the symptoms were not relieved and child was not improving, they transferred the child to our hospital. At our place on examination, eyes were normal. Child was little lethargic. On respiration, there were bilateral crepes. Distress was there. Indrawing was there. The vital CVS, only tachycardia. There was mild hepatomegaly and kidney functions were normal. So in this situation, now what are the possibilities? Can anyone take?
Thank you, sir.
Yeah.
Good morning, sir. Good morning to all. At the outside, I thank the organizers for giving me this opportunity from south end of India. That I think among the audience, I am the person who traveled extensively from the longest distance, where our PM also there nearby our place. Thank you. And I'm happy to be with the great panelists, that to Raju, Shah and Mahesh and all my co-panelists. Sir, and this case, as you presented, it is a very clear to start with 10 months old child with a recurrent history of respiratory infection and typically high-grade fever with the typical respiratory symptom that anyone can think of pneumonia. There is no second thought of it as the history goes on. Only question comes, it is a viral or bacteria. That is a second common. From the history, since the duration of the program and child is getting worsened and the supportive factors are there, that it could be a viral, I mean it's not a viral, it is a bacterial pneumonia. Okay, having diagnosed bacterial pneumonia, why the child has not responded to the common, because in fact, the beginning when they suspected pneumonia in this child, they put on Vanco and Piptas. Usually Vanco is be useful when there is bacteremia where there is typical, it will have a poor penetration to the lungs. But of course, Piptas, which is common among bacteria, as a whole, it is still streptococcal. Pneumonia is the commonest, in spite of being the vaccines are given, but the complicated pneumonias due to streptococcal infection are increasing. What initially pneumonia without complication, but now after immunization, whatever pneumonia we get, so I will think more in terms of pneumonia, that too some drug-resistant pneumonia. Third possibility, it has been extended over a period of 10 days. In spite of all antibiotic, other things, it would have gone for some complication. These are the two things which I commonly think. Very rarely, now we have to think of, because the child gives history of recurrent infection over a period of months, which was simply improved. Whether the child is a immunocompromised child going for a severe infection or any foreign body which is very quite unlikely here. These are the possibilities I will think in this child, sir.
Thank you. Mahesh, can you want to add anything?
Just one or two points. I will definitely like to know the preceding history of this child, if he's had any recurrent infections, how is the growth of the child. You know, that will definitely give me some clue towards probably pre-existing underlying problems, which is not making him resistant. That's one. Second thing is whether we are dealing with something else, like this may be the bacterial, this could be Cox. Going on for 1 month without any kind of a response can be Cox. Third, the distribution of findings, if you tell me it's a generalized, then why not virus? So epidemiology is also important. And a year ago, we are seeing bad adenovirus epidemic. We are seeing so many bad patients who are just not responding. I'll definitely take those into consideration. And finally, not to forget, sometimes you control the infection, but just because of the necrosis of the lung, they keep on getting a high-grade fever. And we landed up few patients doing pneumonectomy as a treatment rather than just upgrading the antibiotics. So here, knowing whether it is bacteria still alive, maybe a bronchoscopy, which I would do in my center. When the fever don't respond in a predictable way in for 7 or 10 days in a bacterial pneumonia, I will definitely want to know the bug. I'll go aggressively get a ball, find out which is the organism and sensitivity pattern, maybe going a CT to know whether there is any collection. So source control is another very important factor in this. You may be having a small empyema which is not being drained, and the fever may not just come down. So those other factors also need to be taken into this.
So thank you, Mahesh. So normally in a case of a community acquired pneumonia, we don't expect that there should be, gram negative organism, and we should start upfront piptas and other things. Normally ceftriaxone should work well. Now in this case, child did not respond and child started worsening. So we have to think whether there is some complication to that pneumonia itself, or there is some congenital anomaly which is leading to this, or something else which is not responding. And just we heard the topic of antimicrobial resistance.
Yes, sir.
There is something.
I will not think of structural anomaly because the child had previously infection got improved, so local structural.
Yeah, but it was complete improvement or was going on. We don't know whether it was because we don't have previous X-rays or anything. So we have to keep this in mind. I don't say that it is the same condition. So one has to try to look at now etiology, why actually it is. So etiologically and anatomically, both we have to look at, and so what further investigations will have. Manish, can you?
So, sir, in any community-acquired infection, with the use of these antibiotics, child should have improved by 3 days of antibiotics. But here, child has not improved, so we'll think of either it is host-related factors, whether his host is immunodeficient and structural anomalies there. Drug-related factors, we have to see the dose and whatever dose has been given, properly given, antibiotics is there or not. Then we have to see bug-related, so it is multi-drug resistant bug or some awkward infection, unusual infection, which is causing there, and complications, as you said, empyema or anything is there or not. All these factors we have to see. So here we can go for further investigation in form of either CT thorax, or as sir has said, if required, we'll have to try to isolate the organism by doing BAL.
Well, this was the, at our place count was high, platelets were also high, CRP was high, hemoglobin had gone down, and this was the X-ray chest and the CT. So a cavitary lesion with air fluid level in posterior segment of right upper lobe with mild surrounding ground glass. So possibility now of infective etiology was most likely. So what next should be done in this case?
As Sir Makesh sir already rightly told, sir, this is CT proves that there is necrotic lesion and fluid cavity, air fluid. Usually when you see a air fluid level, we have to think of an abscess also. It could be a lung abscess along with necrosis. So it is a complicated pneumonia. Definitely ball is needed in this child. We have to do, and we have to find out, because child is not improving. By doing ball, bronchoalveolar, we can do a diagnostic as well as any obstruction also can be cleared so that it can be. So first we will advise bronchoalveolar. So it has to be investigated and the panel has to be done to find out any resistant bugs are there or not.
So right, normally we think that it's a community acquired infection, but as child was in hospital for quite a few days and child was going to the hospital, child had also one more sickness and was going. So probably this could be even hospital acquired infection or some other infection also. And the etiology for necrotizing pneumonias are either staph or probably we all know that nowadays Klebsiella is another bug that can lead to. So we have to now try to find out and reach, as child did not respond to the vancomycin giving for almost 7 days or so, then there is we must try to find out what is the bug. And the BAL, as bronchoscopy was done, BAL was sent, and this is what the report. So in a community acquired infection, sometimes when we think that this is a community acquired infection, but if the child is going to a consulting room, getting IV daily, morning, evening, and then in the hospital, probably they may acquire hospital infection and might have a different bug than the community acquired, that must be kept in mind, and accordingly we must investigate. So this was the case, but then we asked for the biofire, which have shown us that this was again resistance, and we all know that Klebsiella has become most drug resistance nowadays, and we have to go for the special test, that is Carba Expert, and that gives us the idea that what exactly is the bug. And with the now this available only drugs that we can treat, so that is what the AMR is important now, and only drug that was sensitive was colistin and tigecycline. We started with that, and child responded. So if you analyze the case properly, what you have missed, don't just continue keeping in mind that this could be only community and staff only. There could be some other bugs which can lead to that. And
Raju sir, can I make one comment here?
yeah, sure.
I think this case highlights the importance of bronchial lavage. And I personally am absolutely more than convinced with the changing dynamics of diagnosis of pneumonia. I believe in a predictor, as my sir Dr. Ambedkar is to say, you give one particular set of antibiotic for a pneumonia or for any infection. A logically thought antibiotic, if it is not working, you may change it once, but second time it is not working, change the diagnosis. That's one thing. And here in a pneumonia, many times it's very difficult. Suppose your primary set or second set is not working, it's imperative that you have to get a bacteria. The best way to get a bacteria is bronchial lavage. And believe me, it's very safe procedure nowadays. Done in every small town and district is very easily. So many people are doing bronchoscopy and lavage. You get a pinpoint diagnosis, a resistance pattern and a sensitivity pattern, and you get wonderful yield out of it. Quite often people pick up COX. Quite often on a PCR, people have picked up a plain simple virus, which we are unnecessarily hitting with the antibiotic. A repeat CT, contrast and all would cost you far more than a bronchoscopy, and it's extremely safe procedure. So I would urge that people should use this much more often. It's most underused and most yielding investigation that is available in a respirology.
I agree with you, Mahesh, but along with that, one caution that one should not overuse it also, because that's also happening, that even in cases of simple pneumonia, people would start using it. So only
I
in
said
a case,
more than 7 days
Yes,
with a proper antibiotic given.
absolutely.
Second thing, sir, here also, while in ball, both the pneumococcal is directed, Klebsiella also directed. So that again, whether it could be due to pneumococcal pneumonia, gone for complication of lung abscess, or whether, as Sir said, are we over-treating? Whether when you do that, the Klebsiella, which is commonly present as a commensal, could have been directed. That's just a point of thinking for others. But you're
No.
exactly just I thought on that.
Yes, Titi. Yeah, we have sent the those reports also. It was not there, and child responded very well. And just child came for the follow up before about 15 days only, and there is a almost 78%. I mean 70 to 80% clearance of what was there. So we know that this takes longer time for the X-ray clearance, but child was doing, and clinically child was doing very well. Child gained weight and child is normal.
No, I mean, that's perfectly fine. He may
Yeah,
not
yeah,
be,
I
but I'm just
agree.
making
So that's
that
why
for the
there could
delegates,
be a
when you have
primary immune deficiency, one must keep in mind in such case.
No.
Even sometimes you have to keep in mind cytokine storm. As you can see that platelets had gone high, CRP was increasing and hemoglobin had gone down. So, I mean, there are some possibilities that we have to keep in mind. But here, with the BAL, we could get the proper organism. X-ray picture and the CT scan was also more or less correlating, and child started responding within 72 hours of the antibiotics. So,
No, so the only point is that once you have any internal organ abscess, you must at least do an NBT to rule out CGD.
yeah.
The child is going to respond because you are correctly given the treatment, but that's not the end of the story. That's what.
Yeah, sure, sure. I agree with you.
Sir, one submission, sir. Sir,
Yes,
one submission.
yeah.
Now the days of bronchoscopy has come, but in the periphery still we are in the back. So what can be done at this juncture where bronchoscopy is not available or a person is not available?
No, such cases has to be treated in a tertiary care center where the facility.
1 minute, sir. Tertiary care center is entirely different, few are limited. Whereas I am from the basic hospitals, so my approach or the approach that has been established, I would like to submit to the younger people. Once you see a mass or a cavity or a pus-filled lesion, the best thing is to do lung aspirate. It can be done very easily by ultrasonic examination, localization by the radiologist. He'll mark and give it to you. It's the easiest and safest procedure. Second thing is, in this already there was a pleural effusion as per this one. So you can also do a pleural tap and try to find out the cause, provided you don't have a pulmonologist with you. Thank you.
Sir, one more. Sir, in this case, hemoglobin was 6.5. I thought whether it could be a pulmonary hemorrhage also, or probably whether it has gone down and
I mean, other
there is
tests
just
and
one
CT
suspicion, but everything was proved. Okay.
Yeah, so it is. Let's go to the next case because some discussion will going on. So let's look at the second case. A 7-month-old male child transferred to our hospital with complaint of fever, cough, respiratory distress, and poor general condition. There is a child was full term, birth weight was okay. Child was doing well that initially. There is a history of recurrent cough, cold since last 2 months, requiring hospitalization once before 15 days. Child was consulted a local pediatrician and took OPD based medication, but complaints not relieved and child was worsening. So child was hospitalized at same hospital and workup and basic treatment given. Diagnosed having extensive bronchopneumonia with respiratory distress. So consultant felt the need of tertiary care, referred to such facility. Child was treated with meropenem, Venco and supportive care for 3-4 days. No improvement, so transferred to our hospital. This was the findings on examination on respiratory system. There were bilateral extensive crabs with distress, and SpO2 was 84% on room air. Tachycardia was there. Mucopapular skin lesions all over body were there. They were around 10-15 or so. There was a hepatomegaly, no splenomegaly. There was mild abdominal distension was there. And this was the clinical picture: sick looking, irritable, severe respiratory distress, signs of shock, and SpO2 88% on nasal end. So child was ventilated and put on the supportive treatment. The investigation at that time was suggestive of total counts with neutrophilic predominance. Chest X-ray revealed bilateral extensive opacities. Inflammatory markers were very high, high procalcitonin also. Child was on antibiotic, ceftriaxone and vancomycin. They were not relieved, for which antibiotics were upgraded to meropenem and vancomycin. BAL was sent, which was suggestive of pseudomonas, and so changed to ceftazidime-avibactam combination. So now child was admitted, history and everything, supportive treatment, emergency care was given. So what are the possibilities in this case? Yes, Manish, can you?
So sir, here problem started at the age of 5 months. So we would like to see the previous papers of 2 months, whether it was pneumonia or simple respiratory, viral respiratory infections, how the child has been growing in last 5 to 7 months, like child has been growing well, or there is a failure to thrive is there or not. And this time also it is a severe pneumonia. If those previous episodes were also of pneumonia, we'll consider this as recurrent pneumonia or probably persistent pneumonia, either of them, because we don't have X-ray reports in between. So if that's much severe pneumonia in a 7-month-old child, otherwise breastfed child with just complementary feeding, should alarm the suspicion of SRSA immunodeficiency or immune of immunity at this stage. But let's first try to find out, is there any local pathologies there or not, like a sequestration of the lung or anything is there or not. We have to think of echo also to rule out any congenital heart disease there underlying which is causing recurrent pneumonia, and along with that then we have to think the possibility of immunodeficiency later on.
So right, so in a younger child less than 1 year getting repeated infections, this time extensive, there were skin lesions also. So we have to keep that there is some extensive infection. So all these possibilities we have to keep in mind. So what next do we do in that case? Yes,
I think
Mike.
less than 1 year child not responding like this with progressive disease, you need to take a good family history. Any unknown kind of a death causes recurrent infections. Here you have a persistent sort of infection. It's not a multi-system, but again a diffuse generalized infection. And you gave me Pseudomonas. So cystic fibrosis definitely stands on card. And somebody doing a bronchoscopy, if it tells me there are a lot of pus flecks inside, my diagnosis become more important. Before going for that, I would like to know the ABG of this child or electrolyte of this child. Is hypochloremic metabolic alkalosis? That kind of thing give me another indirect clue. And I may straightway go for a genetics in addition to what your culture pattern is shown on this child to me. You have shown a Pseudomonas, I'm sure got a sensitivity pattern. You'll treat accordingly. Meanwhile, you look from these clues. If not, go for a genetics to get a diagnosis. That's how one would go.
Yeah. So, doing BAL and keeping, I mean, general picture and taking a detailed history, we were told that the second child in the family died at almost 2 months of age or so. So, keeping that history, there is a history of consanguineous marriage also. And with this picture, we thought that there is a more possibility of immune deficiency, and so we asked for this test, and this is what the
Sir, very well said, sir. Since a typical family history is there where other child is involved, and this child have with recurrent infection, and this time up to 6 months to have some protection from maternal level. After 7 months, the infection has become very severe, where become resistant and Pseudomonas positive. It's a very good case for evaluation, and immunodeficiency has to be kept in mind. Thank you, sir.
So it's very classically suggestive of the SCID. You find that there were all three immunoglobulins were low, and the lymphocyte subset analysis was also suggestive of SCID. So it was immunoglobulin levels, CD4 levels, as well as lymphocyte subset were also low. So we thought of child having severe combined immunodeficiency. His whole exome sequencing has been sent, but after 72 hours looking at the condition, parents took the child home, Dama. So we don't, I mean, when we called after 48 hours and we came to know that they lost the child. So we are still waiting for the report of the exome sequencing, which can tell us exact diagnosis, but this was it. Yes, Nitin, you wanted to comment?
No, Raju, with the previous child having died and a very strong history of PID, at least one CBC in this child after birth, and you pick up lymphopenia. Because of the circulating lymphocytes, 75% are T cell, around 5 to 10% are B cell, and 10% are NK cell. So if your T cells are gone, your lymphocyte count will really drop. So any ALC, absolute lymphocyte count, below 4,500 in the first 6 months of life is, unless proven otherwise, a T cell deficiency. So maybe this child could have been prevented from all this and straight transplanted, and he could have survived. In USA and everywhere else, they do now what is known as T-RAGs. So they do T-RAG at birth, and T-RAGs are absent. It tells you that the T cells are not there.
Yeah. Yeah, you are right, but actually, what happens that in a normal circumstances, they go to a peripheral, either their general practitioner or to the primary pediatricians, and they are not aware of this. And so, first 4 or 5 months, this continues, and when they have a severe infection, then only they come to a tertiary center, and then, it.
No, so that's why for the pediatrician, when they do a CBC in such a case, don't only look at the count, look at the ANC and the ALC. If you have low ALC, be watchful.
Yeah, absolutely right. And this type of patient where there is already a history of one death of one child, consanguineous marriage, and getting repeated infections from young age, one should have done that primary report, and that could have given us some hint that this child is also likely to suffer from some immunodeficiency. I agree, but this is what is happening in the situations. So let's go to the next case. A 4-year-old male child was complaining of fever, irritability, headache, and body ache. Child was sick looking, lethargic. There was a temperature, redness of oral cavity, dry skin. Liver was 2 centimeters, spleen not palpable. RSCVS was normal. Child was given oral antibiotics and symptomatic treatment. There was no relief. Child was then referred to another higher center by a treating clinician for further management. In that tertiary care hospital, child was reached there with complaint of fever since 5 days, lethargic since last 3 days, few rashes on the chest, mild shock. Child was treated with multiple antibiotic considering bacterial sepsis and antifungal also and supportive treatment. Initially child showed some improvement but condition worsened in last 2 days. So they had asked for a advice of another senior pediatrician. Opinion was taken. That pediatrician thought that this is an incomplete Kawasaki, so treated with 1 dose of IVIG. Child was not improving, and so then child was referred to our center. In our center, on examining the child was lethargic, sick looking, drowsy, few subcentimeters lymph node in cervical region. There was no obvious rash, no organomegaly. Resistance in neck flexion at our place. DTRs were plus, ankle clonus was there, plantar withdrawal was there. So what next step should we take in this situation? Dr. Darur, Rangna, can you say? Okay.
Okay. Thank you, sir. This is clearly progressing to CNS problem. So whether we have to see whether it is a case of meningitis, encephalitis, or anything else, we have to see that. So from the history and the examination, the child is worsening because of the infection. But only thing, child shows some improvement, then deterioration. Whether are we missing anything? I would advise, instead of before going to straight away any treatment, we have to do MRI and we have to do LP also. We have to do with this further investigation. Apart from our basic routine investigation, these two things are very much needed to substantiate what is the exact etiology as well as pathology in the nervous system.
Mahesh, you want to?
Just one thing. He is a child who is having fever for last 4 or 5 days. Without localization initially, on day 3, day 4 started localizing to CNS. Now this kind of localization, somebody has started antibiotics suspecting is infection. Only infection which can progress like this or without is something like we get some shock. We have seen condition which has made somebody unconscious in ICU, apart from infection in the short duration, is shock. So early, look for any evidence of a shock. You mentioned there are some shock findings initially. Yeah. I'll definitely, my priority at that point is to revive the shock first, give him oxygen. Now, in spite of revival of shock, if the child still maintains to be unconscious or lethargic, now I seriously know this is some CNS pathology. Here again, I won't go for a CSF straight away. I don't know whether it's raise ICP or not. It's dangerous to do that. So here, as you rightly said, I will definitely go for MRI, preferably with contrast, if my creatinine is all right. And then if I get clear localization there, if I rule out that this is not raised ICP, most of the times on MRI you can reliably see that, then I'll go for lumbar puncture. In that case, in the present era, infection as well as immune mediated pathology, you see autoimmune encephalitis even coming at 4 years of age, you have seen NMDRs and all those things behaving like this, though the fever is not a presenting symptom, mind you. All those autoimmune disorders coming with CNS manifestation, fever was never here the child presented with high grade fever to start with. So there his contemplation that became a biphasic, where some primary infection, now immune mediated secondary pathology in the CNS. That's how I explain it. So this will be my approach in that case, and MRI perhaps, or subsequent if it allows CSF, will give me some clue towards the further diagnosis.
So we also thought on the same line, and that is why we did CSF as well as we went for the MRI. CSF was within normal limit, HSV was negative. CSF biofire was also normal. So MRI brain was like this. So it was a edema which presented like this. MRI spine.
So predominantly white matter disease, we can see it's all about periventricular white matter and the spinal lesions. So it's a edema, very likely.
So sometimes there can be an unusual presentation of some of the conditions, and some of these autoimmune type of disorders may present with fever, and then there could be unusual presentation, and ultimately the disease evolves in this way. So we have to keep always track and try to find out. This is the child now. The child was diagnosed with edema, responded very well to the steroids, and child was okay now.
Sir, as Mahesh has said, regarding the CSF analysis, for a peripheral practicing pediatrician. Even if the child is in shock, once you have to stabilize. Whenever you do CSF, we have to know the absolute contraindication, relative contraindication, based on which you have to first stabilize the child. Whatever shock is that, it has to be corrected, then only you are going to undertake. Because MRI is a must, but putting the child into the MRI is, when the child is very sick, that also there. But rightly I said, we have to accept. Thank you, sir.
Thank you. Let's go to the last case.
One submission, sir.
Yeah, sir, time is very short, so we have to complete one more case.
The patient which has come in a shock state or it has gone into shock state under your care, the primary thing is to handle the shock and stabilize the case. Once you stabilize the case, then think about MRI and other things. Otherwise, to do MRI, how much time it takes, everybody knows, I think. You will lose the patient.
Yeah,
so
yeah.
the priority, you have to prioritize your case and the procedures.
Absolutely right,
So,
but this, to complete the case in a short time, many things, we have
No,
not,
sir. One more,
that
one more. Yes.
part of
Because-
treatment
no,
is not fully
because,
described.
Because the CSF was normal, LP was done. So then the MRI did show the involvement of a larger area than what we usually find. So it should be a different case, which I think people have discussed. Thank you.
Thank you. So next case is the 7-year-old girl complains of fever since 12 days, severe icteric child complaining of vomiting, abdominal pain, itching and poor oral intake. On examination, child had hepatomegaly, which was soft. There was a tenderness was there, yellow sclera, lethargic and irritable, cannula in situ on the left hand. So admitted our center for further workup. This child was icteric, CNS, child was little lethargic. Otherwise, abdomen hepatomegaly, mild tenderness, and there was a pain over left hand due to IV insertion. Rest everything was normal. And child, the primary investigations were done, which was suggestive of hepatitis A, IgM. Rest everything was normal, and still fever was continued like this. So the USG abdomen also was suggestive only of hepatomegaly. Otherwise, everything else was normal. X-ray chest was normal. The supportive treatment given, but the high-grade fevers continued for 5 more days at our hospital. Child was treated symptomatically, no antibiotic was given. But this was very unusual in a HIV infection that high-grade fever continued. So that was a dilemma. So now what are we missing then? Why fever after 15 days of illness? Is anybody who... Yes, Manish?
So here, 15 days fever you don't expect in a patient of hepatitis A. Even if it is fever is there, it has to be mild. We should not disturb routine activity of the child. So here, high fever is persistent after 15 days. So there is some coexisting illness is there, which is causing fever other than hepatitis A, because SGPT and all those things are not that bad to cause so much fever in hepatitis. So we have tried to find out the focus of fever, like we have to thoroughly examine the child from top to bottom and to try to find out the focus. Somewhere has to be there, some bacterial focus has to be there.
So, absolutely right. We tried to look at, yes, Mahesh.
No, 15 days fever in HAV or hepatitis, we have seen good number of cases lasting, but that's not very high grade fever.
Yeah.
I totally agree. Low grade fever. So few odd things which we see in a common man out. We have seen bradycardia coming up in recovery way. We have seen ascites lasting for longer time. We have seen pleural effusions. So low grade fever is known, but high grade fever, certainly you should look for any co-infection or something. Here you had probably some limb pain, at least you will analyze that. But sometimes you have seen some hidden focus. So I happen to see one neuroblastoma coming along with this and giving us fever going on beyond 2 weeks. And low grade fever, we were just waiting for 2 weeks to happen, and after that we investigated, we picked up her. So there is always a possibility of missing something sinister.
Yeah, absolutely right. So we were a little perplexed. We tried to examine, but we were not finding anything. But then, on day 4 of admission in rounds, one of our relative told that she is continuously having pain in her left arm, forearm, even after removing the cannula. Initially, we thought that it is because, but then on examination, we learned that there was a shoulder joint having restriction of movement and small swelling in the axilla. So this was then USG was done. That was suggestive of there is a septic arthritic changes was going on. So probably what we thought that thrombophlebitis, which was leading to the pain, from there probably infection must have gone, and the arthritis was evolving, so we were not getting those. And then after about say fourth or fifth day in our hospital, we found this. So fever was due to this, and fever responded within 48 hours after drainage and antibiotic. So to conclude, so often we remain one-dimensional while examining the patient in OPD and rely on parents complaining, which often misguide us. So complete examination is a very, very important, and probably recurrent or repeated examination can give you if there are some evolving signs or symptoms or clues are coming up. So here we could save this. So to summarize the total my finding, back to basics, one must remember that even in a tertiary care, one must again go through thorough examination as well as thorough history, which can give you most important hints, and that can give you the diagnosis also. If there is no response to the treatment after your diagnosis, check for complications or new evolving signs. If a young child gets recurrent bacterial infection or gets serious infection involving multisystem not responding, think of immunodeficiency. In a community-acquired infection, if there is no response to first-line drug, rule out resistant infection. And as very rightly said, sometimes you need to revisit your diagnosis also, because it may be a wrong diagnosis. Thank you very much, my panelists, for excellent discussion. And thank you, Kunal and team, for giving us opportunity to talk on this very important subject. Thank you.